Thank you so much, Joe. I think I'm marker, so I tend to be quite noisy, so hopefully I'm not deafening or quiet. Thank you, Joe. Thank you, Catherine, for inviting me, and a fantastic symposium so far. I've really enjoyed it and learned a lot. And I had a particular remit. So Joe's asked that I talk, well, as he said, to sum it up and to bring together the threads of the different sessions and where we are in our thinking about trust, acceptability, and particularly these two words, social license. I think I'm a big fan of the IPDLN group, the biannual conference, which has been running for, I don't know, 10, 15 years now. It's the community that's really come together to think about how we do data science in an acceptable way, and the technologies underpinning it. And if you speak to anyone at that conference, in that community, if you look at the papers published in the House Journal, IJPDS, social license comes up as a concept time and time and time again. And it does so for a very important reason. So I'm going to try and articulate that today. And it's based on a little bit of a quick trip down memory lane. It's then based on my personal experiences and what shaped my views on social license and why it's important, and what it means, and what leads to social license being in place or not. And then to talk about some work I've had the privilege of leading as a community endeavour led by the HDR programme, which I'm part of. So, starting off with my LLC hat on, thanks to a vast array of people, which has made everything that we do possible, including public contributors, studies, infrastructure providers, and hundreds of thousands of members of the public who take part in these research programs. As I say, I'm going to start with a recap. And I didn't know whether this was necessary. I thought I'm going to talk about care.data. I thought surely everyone knows about care.data, but apparently people don't know about Cambridge Analytica, and maybe I just need to place this in my timeline rather than assume it's in everyone else's timeline. So 2014, I think 2013, 2014, the government had a very long-standing ambition to build a centralised database of English GP records. Equivalents already existed in Scotland and Wales and internationally, and they were providing incredibly insightful. The GP record is at the heart of the clinical pathway. You really need to be able to access the GP record to make sense of people's patient journey and their health experiences. It was launched and it quickly fell flat on its face. I mean, these are just a snapshot of some of the adverse publicity that it faced. The GPs, or some GPs, very vocally mobilized against it. The media then caught on, and even supporters like Ben Goldacre, who had initially come out in favor of care.data, had to row back and actually say this is an ill-conceived design. The principle is right, but the way it was launched was ill-conceived. Subsequent reviews about past practice at the NHS Information Centre, what's now NHS England, revealed broadly very good practice with a few not so good examples. But what happened subsequently was we moved from an area where I think it'd be very harsh, and I don't want to misconstrue it, that prior to this, data sharing at NHS was somewhat of a cottage industry. And what I don't want to say is that it wasn't thought through properly and care wasn't taken, and good people, thought very hard about what was right and what was not right. But it was done with a level of resourcing which wasn't anything akin to what we've got now. Post care.data, the system has evolved and continues to evolve in the way that most of us are probably aware of and are experiencing that. So after care.data was proposed, after the adverse response, we started as a community to think about what went wrong. How can we make this work? How can we go forward to actually enable this? And I think this is the key paper which came from that period of time. So Carter et al., the social license for research, why care.data ran into trouble. And basically their key observation, and I think this is paraphrasing rather than a direct quote, was for an initiative like care.data, but any data science work, to be publicly and politically acceptable, That use of data needs a social license, and that is achieved through legal compliance and information security. Yes, absolutely, obviously, but that's just the start point. We need to go beyond those two things, which is what care.data really focused on, to think about fairness. And there's all sorts of terms which can be encapsulated in fairness, and think about ethical standards, inclusivity and equitability, the respect for individual rights, the delivery of public benefits, the voice of the public in decision making. All those things can be encapsulated in my mind into this term fairness. But what would be better is just to think of those as being absolutely essential dimensions of social license. I want to quickly tease out social contracts being mentioned a little bit. I think there's a big distinction between social contract and social license. So I think a lot of what we do needs a social license. I think social contract, in my mind, and I think this is one of those areas where terminology doesn't have a consistent definition, which isn't helpful. Social contract envisages reciprocal sharing of parameters and agreement. I think it does exist in like consented situations where people are saying, how are you going to use the data? I agree under these terms. But what we generally do with whole population data is seek to create an environment in which a data use can happen. And actually the public, as we can see in care.data, can push back. But actually what care.data didn't do, one of the things that's a failing of it, is have that social contract. It didn't make clear what it was trying to do and how it would work. So it didn't have that bedrock, which the contract would have, which the public could buy into. That was one of its failings. So, and the way Carter expressed it, I mean, which I've just sort of mentioned, the conditions were not set to establish trust and acceptability. There was no real detail about who was going to use the data for what, where copies were going to be generated, where they were going to end up, who was going to control that, who was going to audit it. None of that was clear at all. Care.data breached societal norms. There's a long-standing tradition in this country, and Joe was right at the beginning of the day to talk about global variations in how societies view the exchange and use of data and other things. But in this country, there's a long-standing tradition about confidentiality between the patient-GP relationship. It wasn't clear whether this threatened it or not. And as I say, it wasn't clear who was going to use the data for what purpose, and therefore the public goods and that return to society wasn't clear either. But a really good thing came of that. Actually, it was really exciting at the time. For my journey, again, before care.data, I was very much focused on longitudinal consented studies. I was working in that community. I was starting to explore things like data safe havens. I'm going to talk about that in a moment. But what happened afterwards is we really came together as a community and through initiatives like Understanding Patient Data, where we collectively, as a broad tent with privacy lobby groups, patient advocacy groups, public representatives, clinicians, professionals, researchers, technology experts, we all came together to think about how we're going to make this work, to think about how we're going to make the purpose and use of data and the methods clear, how the benefits are going to be transparent, how we include the voice of the public and co-develop our activities, how we respect rights, how we basically have better data husbandry, to think about trusted research environments where we know where data is and who's using it for what purpose. Initiatives like the 5 Safes generated, slightly adjacent to this work, but around the same time, and really all coming together to try and build that social license. 5 years passed where we did an awful lot of work. We had a pandemic, and that really accelerated the development of a lot of really good initiatives, transformational ones like Open Safely, for example, for GP data. And midway through the pandemic, the system, for want of a better word, tried again. It developed an awful acronym, but basically it was care.data 2. And it was genuinely care.data 2, and it had the same response. And it felt really frustrating to be someone who'd worked really hard in that intermediate years to think about how we can do this better. And actually the lessons weren't really listened to and weren't learned. And there wasn't enough clarity. And really, I thought about how to do this. And I apologize to Carter and the other authors because I didn't get their permission to butcher their paper in this way. But it's the same story repeated. And possibly this was their justification. They just thought, well, everyone knows the value of data now. Surely we're living through the pandemic, we can see how, you know, all the vaccine trials, everything, people were looking for answers, people were looking for the outcomes which our work can produce. But actually, I think this is one of the first lessons I'll come back to over and over again in this talk, is what drives social license isn't momentary things, isn't fine detail, it's enduring high-level principles. And COVID-19 didn't change that. It didn't change fundamental rights and what people think of as fair and not fair. It expedited the use of data in a particular crisis situation, but that didn't shift the dial on what was important. What was also completely overlooked is, and there was a lot of emphasis on involving the public and communicating, but what was also overlooked was the public aren't the only important stakeholders in this. The voice of the clinicians, and in this case the GPs, was also completely overlooked. And one of the things we did, a group led by the fabulous Liz Ford, was look through what the GPs were saying around the time of care.data. We did a systematic review of the mainstream media, GP publications, and forums, and did thematic analysis of what GPs were talking about. And actually, GPs got what care.data was intended to do. They saw the benefits, but they didn't like the fact that at that time, patients didn't have an informed choice. They couldn't opt out. They didn't like the fact that, and this goes to who owns data, in terms of GP data, the GPs are businesses, they're commercial entities, they own the data, but that also means they have liability for the data and misuse of the data. They didn't like in any of this that it wasn't clarified about whether they were let off the hook for that liability, and if there was a central database they had no control of, whether they were still legally responsible for that data. That obviously, as a business owner and someone could end up with theoretical jail time, that's a genuine concern. They were concerned about the lack of clarity, the lack of safeguards, the fact that and I can't even say the acronym, the second thing, GDPR, DPR thing, and that was one good thing about failing, is that acronym's put to bed. The custom research environments still weren't mandated. They were talked about, but they weren't essential. We hadn't moved to that TRE by default. And again, I mean, goodness sake, language, data safe havens, TREs, SDEs, I think of them as exactly the same thing. So different people call them different things, not helpful, but that's where we are. I tend to call them TREs. And they still were concerned about the trust between them and their patients. What had changed is there was an effective opt-out mechanism by that point, and the public did vote with their feet. And that actually is quite a lot of public involvement to double the rate of opt-out within the space of a month. Okay, so that's the backstory. That's where the term social license came from. It's a recognition that the system cannot do what it likes with data without the goodwill, buy-in, understanding from the public. And there are a whole load of technical and governance things which come together as a patchwork sort of quilt, for want of a better word, which envelops all that and makes it acceptable. But in my view, it's the high-level principles about fairness and rights and motivations which really drives the phenomenon of social license. So then this is my personal story about what I was doing before that time, during that time, and after it, and why that shaped my view of social license. So I've worked my entire career in consented longitudinal studies. This is a fantastic part of the UK data landscape. These are studies where participants are selected based on a select collection of shared characteristics, and they're invited to take part in research. They're active volunteers. Typically, they're consented. That means a whole load of things, because one of the wonderful things about this is these longitudinal studies have been running since the 1940s. So the 1946 birth cohort, everyone born in 1 week in 1946 was eligible to take part. Those participants are still taking part. They just had their 80th birthday. Isn't that amazing? 80 years of continuous follow-up in one study, providing a wealth of data, living through transformational change, computers being created, genetics emerging as a thing. All these things which we take for granted in our current research landscape, these participants, their journey in their study has evolved as the opportunities have evolved around them. And to make that work, it needs to be based on a foundation of trust. So every study PI will tell you what's the most important thing in your study. It's the trust of my participants. Without that, there's nothing. So it's been incumbent on us since the 40s that when we run a study, when we think about how we use data, how we think about the next step, the next opportunity, we start with thinking about trust. We start with thinking about social license. We didn't know those words until Carter et al., but that's what we were thinking about. And what I'm going to show you basically is, from consented study, a different lens on the same issue as care doc data. I worked at Alsbach, or Children in the 90s, which was, or is rather, it didn't finish when I left, a study of 14,500 families from the Bristol area. All these families, the children were born in the early 1990s, so they're millennials, they're in mid to late mid-30s now. 14,500 families took part, incredible commitment. By the time the kids were 18, there had been 55 assessments of everyone in the study, and probably another 55 of subgroups. But 3,000 families had done everything, 55 things over 18 years, and 8,000 families had done most of it. Just so, and it was generating tremendous benefits in terms of scientific insights and outputs. And another indication of buy-in and trust and enrollment is now 3,000 children of the original study children have been enrolled, a unique 3-generational resource. And just to put a bit of emphasis, in the late 80s, Jean Golding, the founder of Alsbach, was designing the study, and she was thinking about social license then. Alsbach had the very first faculty ethics committee in the whole country. So no university had ethics committees then. One was created for Alsbach, and it had participant involvement in it from day one in the late 80s. These were huge innovations then. There's a lot of emphasis on security of data, keeping identifiers separate from data, which we would think of as, like bread and butter of 5 safes. But this was a paper-based system. The study was run from an Amiga 500, which was a computer system rich American kids had for gaming. I mean, everything was basically done in these box files you can see behind Jean. But trust was at the heart of it. There was a lot of community engagement, working with faith leaders, community leaders about getting the trust of particular community groups. There were field workers going out to families with low literacy levels to make sure they were included. And participants were told what was going on. Newsletters were going out all the time. The local media were running stories all the time. People felt they were bought in to the study. And this was fantastic for that engagement, but I'm going to talk about my social license story and how it was challenging in that case. So I've been working at Alsbach for a while, and then we started off on IT software development, and then moving on to thinking about record linkage. Really, this kick-started in 2009 with a Wellcome grant, where the kids in the study were just about to turn 18. We thought we need to consent them as adults, now that they're not part of the study as kids. And we want to think about, when we do that, we can also ask them about the use of their routine records and set up linkages, not just to health records, but also to education records, HMRC and DWP, which gives employment, earnings, benefits, and criminal justice. So a spectrum of linkages. And we knew that was sensitive. So right from the start, we thought about setting up a TRE to do this. And we wanted participants involved, not only in co-development of materials and making sure things were accessible and laid, but also in the decision-making process. And then to get a really deep insight into how participants felt about this, to do in-depth qualitative 1-hour-long face-to-face interviews with a representative sample of the cohort, from those who were really engaged to those who were disengaged. And what we found, one of the things we found from those qualitative interviews is we framed them using a methodology where we basically talked through what we were going to do, why we wanted to do it, and we set a range of scenarios about different research projects. And we talked about the fact that by this time, and I think it's in the next slide, a lot of participants have dropped out of active follow-up. I mean, 17, 18-year-olds, they're not the easiest group to engage because they've got an awful lot of things going on in their lives. And we talked about fairness a lot, and we talked about these scenarios about how we balance things like asking for opt-in consent against the fact that that would miss some of the harder to research communities, parts of our participant group, and it would lead to inequitable research findings. And participants they understood fairness, stigmatization, issues like that were really high on their agenda in terms of the things they were concerned and motivated about. But they also were really keen on the idea of opt-in consent and the fact that they were empowered to make the decision. And it wasn't just about rights, it was also a sense of etiquette. So we sort of made a rod for our own back. Since the kids were little, we've been training them effectively in consent. Even when we were using their parental consent, we were always asking the kids, as they were then, for their assent to take part and saying, if you don't want to do it, don't. Just say. So we built this culture of consent, which was integral to our trust framework. And now we were starting to explore what was the right thing to do at age 18, where we know if we're going to ask for consent, we're going to get biased consent. We did an analysis, as I've just said, at age 17, 18. It was quite clear that the people who were active in the study were more likely to be female, have quite significantly higher educational attainment to those who had dropped out, and to be much less likely to come from households with low levels of income. We couldn't, without doing the record linkage, it was obviously quite hard to be more precise, but we knew that a consent campaign was going to be biased. We did try it, we piloted it. So this was a pilot of 2,000 participants, heavily overrepresenting engaged participants. About half that sample were very engaged, our most engaged group. We mailed them this really informative consent materials, which have been co-developed with participant advisors. Only 41% responded. We're not surprised about that. And the pattern which came through was exactly what we predicted. And it was based on what the typical response is, and actually what's typical in all consented cohorts, no matter which country you look at. Well, of those who did respond, the actual consent rates were high. So, which is kind of not surprising, it's slightly intuitive, but what we gave people different options so they could, they weren't forced into an all or nothing approach. And that variation in consent rates was actually quite useful in terms of demonstrating that people had autonomy, they did understand the way we were framing things, and were able to pick and choose how they wanted to be engaged. We didn't say, to carry on in Alsbeck, you need to agree to any linkages. It wasn't mandatory at all. But we were left with what's effectively a moral dilemma. Do we go down opt-in consent? This is the social license route. This is what we've heard from our participants. They want autonomy. They value consent. It's part of this learning on social license. This social norm, we established opt-in as the social norm. It was built into how they had grown up from babies through to being adults. Or do we go down opt-out? Perfectly legal. There's section 241. I'm not going to go into it, but it's I think Joe mentioned, someone's mentioned it already today. It's a way of doing this without needing explicit consent. So this was our option. Opt-in consent, we'd get 40% response rate with a biased sample. Opt-out, we might risk trust, but we would be able to link an awful lot of people, the vast majority of people, and have much more inclusive and equitable research. And we went with opt-out. And we thought hard about how we were going to try and do opt-out whilst retaining social license and trust. And we had I'm being slightly flippant in the next few slides about how I'm presenting it, but in the pro-social license column, we had participant co-development. We had participant involvement in key decision-making processes. It was a TRE, mandatory, all linked data will only be analysed via TRE. And bear in mind, this is way before care.data. This is when TREs were actually quite rare. We had the right to opt out, so people still had a means to say no, and the fair processing was really good. It was very clear. It had been through a huge amount of review and development, and we worked with the NHS to place everyone So we really made efforts to find everyone and to give them the information. We had on the pro side the fact that we were doing this for research equity and to be fair across the society. And we developed a social contract. So where care.data didn't say how data were going to be used and under what conditions, what people now call the guardrails or tram lines, we had that. We had a set of bullet points, which were first and foremost saying, this is how we will do it. This is who we'll work with and which conditions. All the independent ethical reviews and security side as well. But counter to this was the fact that we were moving to opt-out. So you'd think, is this naive to think that actually we're on safe territory here? And to a large extent we were. So what happened in the majority is we sent all the fair processing out. We had several hundred, between 200 and 500, I can't remember the details, sorry, I should have looked it up, objections, and varying across the different linkage options. It worked as we'd anticipated. Those objections proved it worked, proved people understood, and proved they had an easy mechanism to object if they wanted to. But actually, we also got some really upset people. Low numbers, 10, 15, something like that, but really upset. And I had quite a few phone calls with parents or children or young adults as they were by then. And it was hard because children in the 90s was something they really, really enjoyed doing. It was a good thing in their life. It wasn't a shitty part of the world. It was a really positive way that they could make a difference. And we'd broken that trust relationship. And that wasn't easy. And, I was thinking at the time that, that mantra that if you're an MP and one constituent writes in, they're probably saying something that 50 or 100 feel. So we knew we hadn't done, we tried our best and we tried to do it for the right reason, but we knew we'd change something. So it wasn't to be taken lightly. And that's really what shaped how I view social license and what I'm going to talk about next. But a little bit more detail on Alphabet first. What we then went on to do is we linked almost the entire baseline sample. So it did work in terms of our scientific objectives and our equity and inclusion objectives. Retrospectively, with much more detail, linked data on the outcomes of the 18-year-olds, we proved how biased that consented opt-in group would have been and how harmful it would be. We also linked to data of some of the most marginalised and vulnerable communities in the country who are heavily under-researched and don't get the benefits research brings. And in this case, this was kids in the care system. The number of kids in the care system in active follow-up in Alphabet by age 18 was counting them on one hand. I'll suppress the number for low cell count. And it's because, we needed the mum to have that contact. These kids are all over the place. They're moving from place to place to place to place. We lose track of them. They go into the system. We can't follow them. But through linkage, we could. So in some ways, this really, really did work. And people benefited in terms of research outcomes, who wouldn't have otherwise. I'm not going to talk long about LLC. It's my passion. I talk about it a lot. But relatively soon after that, I moved on from Alphabet and basically took that concept and turned it into a national service to support all consented longitudinal studies, apart from the big beasts like Biobank and our Future Health, who got the resources to do it themselves. But what I really wanted to do was to think about how we did that in that way that carried over the trust, and how it's not me they trust in the TEDS cohort or the Twins UK cohort or the Nicola aging cohort in Belfast. They don't know who I am. They know their Gene Golding. They know their field workers. So it was what was important in what we did in children in the 90s and what's important what they did in their studies, how we turn that into a national service, which we've done, 20 studies, 27 I think it is now, another 30 in the pipeline, over 500,000 participants, 2 million more coming through. So it's happening at scale. I'm not going to talk about how it works or what we're doing. What I will say is the way I think it works, the way we've carried that trust and hopefully carried that social license through, is because we're doing it as a genuine partnership. So this isn't me and my team taking control. It's a co-design between us and the study data managers, their PPIE people, their comms people, their ethicists, thinking about how this works. Every design choice is a collective decision. We're informed by study level PPIE, and we're informed by our co-development process with our public contributors. Critically, thinking back to that point I made about care.data, the big picture principles, whose data is linked to what, who gets to use it and for what purpose, all that stays with the study. That's still under their control. Those big important things have not changed in any way. SERP have been brilliant, they provide our tech, but the important thing about that is the data stays in the UK. It's in the TRE and it's in the UK. That means a lot to a lot of participants. So, I started that journey in 2009 when I was writing the ethics protocol for that linkage program at ALSPAC. I'm a details person, and I was thinking about all these different Venn diagrams, which are all a control, which we talk about in terms of 5 safes and TREs and public involvement and data access agreements and audit checks and blah, blah, blah. And I thought there's a sweet spot in the middle. And if I can get everything aligned, there will be this magic place in the middle where everything's rosy and great. And it just doesn't work like that. So actually, that's like herding cats for a start, but also it's just not pragmatic. And it's not the fact that it happens and then it's fixed, even if you can get to that sweet spot. It's context-specific factors, and things shift over time. Palantir comes along and rocks the boat, or care.data, or GDPR, or the commercialization of data. The context in which all this happens changes. So I'm much more pragmatic now. I don't try not to let the perfect be the enemy of the good. And I focus on these core principles and try and think about how not only do those principles exist and how we uphold them, but how we root them in their specific contexts. What might work for a cohort in East Anglia, is that going to transfer to Northern Ireland? Well, probably not. It's up to Northern Ireland really to help shape how things work there. And what that leads to suggest is we need some principles-based framework to help us guide us to taking those big picture principles and think about how they work for our context, our project, whether it's, for whatever project it is. And we're not the only ones to recognise this. This is a communique from Sir Patrick Vallance and G7 contemporaries at the heart of the pandemic about what went wrong, why the system wasn't ready for such a monumental crisis. And first in their list, they said, what we need is a principles-based governance system which can react to changing circumstances like COVID and allow us to be nimble in terms of how we mobilize data for different projects, different use cases, and into different circumstances. And this is where I'm going to change hat and logos and formats. I'm going to put my HDR UK hat on and talk about what we think as a community endeavour might be the solution to that. So what we've done in the last year or so is develop the safeguards. How am I doing for time, by the way, Joe? Which is a principles-based governance framework for responsible and ethical data research. We're aiming big here, like a framework which encompasses everything, an umbrella framework, right? Trying to encompass everything which social license talks about. So I'm going to first talk about one which everyone knows, 5 safes. Governance framework, which basically allows you to think about decision making, about how you balance data confidentiality with data utility. Fantastic. It's really, really useful. It's very easy to apply in terms of it doesn't tell you what to do. It tells you the things you should be thinking of and then allows you to think and explore those in your context. It's not only allows you to hopefully come to the right conclusion, but it also allows you to communicate that to the public. That's one of the 5 safes strengths, is that it's very easy to communicate and it resonates with the public. When you talk to them about confidentiality and utility, they understand that's the intention, and this really helps convey that principle. I like to think of it, and other people have used this analogy, it's like a studio music mixing desk. If you see those sort of like music documentaries with the, like going to Abbey Road and the Beatles are mixing and they've got all these slider bars. So you can dial up or down the different controls. So on the left, and this is just illustrating that 5safes doesn't tell you what to do. This is putting a data set up on the internet. Anyone can use it for any purpose. You've got no control over it whatsoever. So you've got no control over who, no control over what, no control over the setting. They can just download it and then take it where they want, and no control over the output, i.e. what it's going to be used for. So all your control has to be on the data. And generally that means you're going to aggregate the data to population statistics where they've gone through a disclosure risk assessment, and we're pretty confident they can't be re-engineered to data about an identifiable person. But that transforms the data in an unhelpful way for data utility. Obviously, what we do is use rich individual data about members' populations at the heart of a lot of the statistics that you guys do. I don't do, but you do. So instead, if you put the data in the trusted research environment, you can put all the controls on the person: training, vetting, contracts, the project, ethical review, audit checks, the involvement of people with lived experience. The setting is the TRE, the data, we know where the data is, we know it's safe. And then the output, that goes through the same sort of disclosure checks, and statistical results come out. But that means you can minimize all the changes to the data themselves. They're both equally safe. The framework and the principles allow you to get to that endpoint where you're comfortable about how the data is used, and social license to an extent is maintained. But thinking back to what I've said about social license, there's a lot of things that aren't in 5safes which we know to be important. So we've heard today, and the public contributors today articulated it far better than I can, how important it is to have a public voice in what you're doing, how important lived experience is a lens to shape your research. That's not in the 5safes, or it's not clear it's in the 5safes. Things like research equity, that's not really in the 5safes either. Things about how we make sure we're trained, think about the PEDRI standards and the professionalization of PPIE, and starting to move to think about really rigorous evaluation of PPIE, and that sort of training, career progression, and even the public contributors talked about that. That's not in 5safes either, but they're all important, and they're all part of what comes together collectively to build social license. So we want to propose GUARDS as a acronym. So some of these terms are slightly forced to get a nice acronym, I acknowledge that, but they are about high-level principles. So research that using data about people must be guided by and respectful of a range of diverse public and professional practices. The biomedical people in the room, great to learn from the social scientists, and vice versa, and more widely in terms of interdisciplinary perspectives. I've had the pleasure of working with an anthropologist on public involvement for the last couple of years. I've learned a huge amount from that. That's been great. So it's about the public and different professional perspectives guiding what we do. What we do needs to be understandable and transparent. So things like data use registers and common words. Why are we talking about SDEs and TREs using different terms? That's not helpful. Someone said we're viewed as a collective by the public. The trust is in the collective, it's not in individuals. The weak links, the bad practice are the things that shine through. So we need to be strong. And that links with aligned. Have aligned governance processes, it's efficient. 5safes is great. ONS approved research. Who's an ONS approved researcher? Lots of you. Brilliant. What's wonderful about that? 5 years, and you can hop from TRE to TRE, and it's rigorous. You know, it's not an erosion of a control. It's a sensible alignment across the landscape, which makes a good control also efficient. That's what we're looking for. Responsible, building and research equity. And this relates to both the outcome, that harder to reach communities are included and the research outcomes are fair, but it also is opportunity. That researchers from LMIC countries can access our resources, and that our interactions with them in global research aren't extractive and exploitative. So thinking about how we can make what we do in terms of access fair, and we heard really, from our public contributor earlier how important that is in PPIE. Deliver. This is a two-step thing. So deliver public benefit, we hear time and time again, that's an essential dimension of social benefit, but also deliver in terms of being ready and responsive. When the next situation comes along, whether it's another pandemic, whether it's the impact of climate change, we need to be ready to inform the system, to help the NHS, to help the public and do our part. So that dependability of what we need to be needs to be baked into our design. We need to be road testing those scenarios so that we can, in the matter of, I don't know, that's someone talked about 100 days challenge, be ready for the next thing. I think we should be quicker than 100 days. Stewardship, recognizing that we need to be professionals and we need support, that it's team data science, the PPIE, data processors, governance experts, ethicists, the whole range of skills which go into the back end of running things like TREs and research programs. There needs to be effective career tracks, training programs, measures of success, community groups, and support. What we don't talk about in guards is the things that 5safes do really, really well. So it doesn't talk about anonymization and balancing utility with privacy, because 5safes do that beautifully. And actually what we think we should be talking about is safeguards, which is bring together all the joy of 5safes with this broader set of principles. And together, just to reinforce a couple of points, it's meant to be a holistic framework to help guide decision-making. It's none of that, you'll think, oh, that's not new. Yes, we know we need public involvement. The point, it's not meant to be new. In fact, it would be wrong if it knew. These are meant to be big, high-level, enduring principles, which we know are going to be relevant in 10, 20 years' time. It's about pulling it together into a framework which helps us balance these things which contribute social license. This framework has been co-developed by a very broad perspective of organisations. There's been a lot of public involvement as well. Multiple, I think 50 public advisors from the HCR network contributed. And we've got ongoing co-development, and particularly an international focus now about thinking about how far does this extend? Does this work internationally? What we're thinking about, a bit like the Pedri standards, is to think about aspirations. And again, start thinking about minimum viable product and getting alignment and getting people up to a nice baseline. And then these can be dynamic and we can build on these over time and get more ambitious as we move forward. And each of these principles aligned with aspirations, and also look for an example. So naturally falling under line, it's not reinventing principles. Things like FAIR is important. We're not trying to reinvent FAIR. FAIR does a great job of talking about how we make maximum reuse of research value of effort and research projects. That comes into things like alignment and responsibility rather than having to be reinvented. Let's skip through those. We started building a safeguards toolkit, which is evidence of good practice in these each of the different guards, looking at different organizations which are doing things well, different toolkits, pointing to what exists and what works already. And now, with this next round of consultation, starting to think about how to make this an operational, useful product, actionable. As I said, 5safes is brilliant because it actually, people who are making these decisions find it very, very helpful. Safeguards will work if we're equally helpful. Is it right to think about it as an extension of these slider bars and customizable things? Well, things like guided by public voices, certainly in LLC, where a project is using particularly sensitive data, or we're using new methods like AI, then we ask for project level PPIE, as well as our standard public review panel in data access. So that could be dialed up or down based on the context. Understandable, again, if you're using something like an innovative method, maybe you need an animation or some infographics to help explain it. But we need to explore this, because some of these principles like alignment and efficiency are more incumbent on the infrastructure providers in the system than the researchers like yourself. So we need to explore about how this works, whether it can be thought of as an extension of 5safes, so it's more cross-cutting or differentiating the different roles and responsibilities of the community in this. Okay, two last slides, wrapping it up. So I think it's fair that, as Joe thought, that we need to really prioritise social licence in our thinking. And I was really pleased when I heard that point about the fact that we are viewed as a whole rather than independently. And actually, I'll come to this in my next slide, that it's incumbent on all of us to be thinking about this. So the public are pretty consistent in terms of what they think is important. My view from my experience, but also the many public dialogues and engagement events, involvement events I've been part of, is that social license isn't about the detail. It's not about TRE split file protocols or what small cell value you've got and all that sort of thing. It's about the big enduring principles, societal norms, and the fact that most people participating actively in research are driven by altruism and public benefit, and those who are more passively contributing in whole population research are again minded about fairness and public benefit. So it's vital to understand what your specific factors are. We hope the safeguards is a means to help tease those out for your context. And then we need to manage changing expectations. We need to be responsive to global events. You know how complex society is. I don't need to labour that point. The public are not the only key stakeholders. We tend to often forget the voice of the clinician and the teacher and the different community group stakeholders. We forget, as we were told about earlier, the fact that some families collectively make decisions rather than individuals. So we're not thinking enough all the time about specific contexts and differences. Social license is not about governance, but the solutions tend to lie in governance. I really like Johnny's different perspective, who's really technology driven, and I like that as well. But I think, you made the point as well. It's about a marriage between the two, but really it's about getting the system to adapt to this. So I've already said this. Building and maintaining social license is everyone's responsibility. The researchers amongst you, think about fairness in your research design. Think about how you communicate your methods, your purpose, your intent, your benefits to the public. We're judged as a whole. I've said this so many times. I'm going to say it again. I know none of you can probably make this happen, but can we please get data science on the national curriculum? If we're going to make a step change in how the public view this, we need to educate the public. It should be from early years right the way through. It's not hard. It fits through so many different subjects. And that, I think, is the biggest thing we can do to shift the dial on social license, as well as us behaving in a really informed and responsible way. Thank you.